Welcome to this explainer where I, Harshal, am going to help you demystify the incredibly strict rules behind Medicare preventative services and E&M co-billing. Today, we're tackling a massive intersection in healthcare documentation. We're going to break down the exact framework of the initial preventative physical examination, annual wellness visits, health risk assessments, and how you can safely navigate scene-day problem co-billing without triggering a massive audit. If you've ever felt completely overwhelmed by Medicare's statutory exclusions or those tricky modifier rules, well, you are definitely in the right place. Let's get into it.
All right, let's take a quick look at today's agenda. We're covering 1. Wellness versus traditional exams, 2. The Welcome to Medicare visit, 3. Annual wellness visits or AWVs, 4. Co-billing and modifier 25, and finally, 5. Top audit red flags.
Section 1. Wellness versus traditional exams.
Look, there is a fundamental divide in our coding logic here, and this is exactly where so many practices make their very first critical error. On one side of the coin, you've got your traditional preventive CPT codes. That's 99381 through 99397. These represent comprehensive physicals, your classic head-to-toe exams. But here's the kicker. Medicare statutorily excludes these routine physical checkups, absolutely will not pay for them. Instead, Medicare wellness visits operate on a completely different framework. They aren't actually focused on a physical exam at all. They're all about risk assessment, health planning, and screening orientation. And the eligibility? It's not based on whether the patient is sick. It is tied entirely to super strict timelines based on their Medicare Part B enrollment.
Moving right along to Section 2, Welcome to Medicare. So, looking at the patient journey timeline, you've got to notice this incredibly strict eligibility window. The Welcome to Medicare visit, officially called the Initial Preventative Physical Examination, or IPPE, billed under code G0402, is a once-in-a-lifetime benefit, and it absolutely must happen within the first 12 months of the patient's Part B enrollment, period. Now, this isn't just a casual meet and greet. This visit has highly specific mandatory deliverables. You literally can't just chat with the patient. You must conduct a medical and social history review, a depression screening, a functional ability and home safety evaluation, get those vital signs and visual acuity measured, discuss end-of-life planning, and provide a screening ECG ordering or referral. Honestly, if you miss even one of these components, you just haven't met the criteria for G0402.
Now, you might be wondering, what if they miss that first year? Well, the crucial point to remember here is that a patient does not actually need that initial welcome visit to be covered for annual wellness visits later on. Say a patient enrolls in Part B and doesn't step foot in your clinic until month 13. That Welcome to Medicare window? It's permanently closed. But don't sweat it, because they're immediately eligible for the next phase of care. As long as they've had Part B for a full 12 months, they transition straight into the annual wellness visit track.
Section 3. Annual Wellness Visits, or AWV.
All right, here is how these codes perfectly map out. You're going to use G0438 for the initial AWV. Just like the IPPE, this is a once-in-a-lifetime code, and it becomes available either 12 months after their Part B enrollment or 12 months after their IPPE. Then, for every single year after that, you'll bill G0439 for the subsequent AWV. That one is an annual benefit available 11 full calendar months after the previous AWV. But listen closely, because here is the absolute non-negotiable part. Both G0438 and G0439 require you to administer and review a standardized health risk assessment, or HRA. You also have to establish a list of their current providers, review routine medications, do a cognitive impairment assessment, and map out a 5 to 10-year personalized prevention plan. Guys, the HRA is literally the engine of the AWV. If it's not documented, your whole claim just collapses.
Let's jump into Section 4, Co-billing and Modifier 25.
We see this absolutely every single day in practice, right? What happens if you're right in the middle of a routine wellness visit, you're navigating their HRA, setting up a prevention plan, and boom, the patient hits you with a significant acute illness on that exact same day. Maybe they bring up severe worsening joint pain, or you suddenly discover uncontrolled hypertension that needs immediate, complex management. The big question is, can you actually get paid for both the preventive work and the problem-focused work?
Well, the answer is a resounding yes, but you have to use modifier 25. This 2-digit modifier gets appended to a problem-oriented E&M code, think 99202 through 99215, to prove you performed a significant separately identifiable service right alongside that wellness visit. You're basically telling the payer, hey, I did all the wellness deliverables, but I also had to completely shift gears, put on my diagnostic hat, and evaluate a totally separate acute or chronic illness. Oh, and a quick pro tip for you. This is exactly where you might co-bill a social determinants of health risk assessment using code G0136 if you happen to identify specific social risk factors during the encounter. But hey, you've got to be careful here. As the CPT guidelines clearly show, trivial abnormalities absolutely do not justify problem-oriented EM billing. The abnormality has to require actual additional work and the performance of key components of a problem-oriented EM service. A minor sniffle, a quick prescription refill, or just answering a simple question? No way. That does not justify Modifier 25. The problem must be significant enough to warrant its own totally separate history, exam, or medical decision-making process that stands completely apart from whatever you did for the wellness screening.
Which brings us to Section 5, Top Audit Red Flags.
Because knowing the rules is just half the battle. Proving you actually follow them is the rest of the game. To stay compliant and dodge those nasty downcoding penalties, you have to be laser precise. Auditors are hunting for vulnerabilities right now. They're looking for practices reporting the initial AWV G0438 year after year, instead of correctly switching to the subsequent G0439. They're definitely checking for IPPs billed outside that strict 12-month window. But the most dangerous trap? Double counting. You cannot, under any circumstances, use the medical history collected for the wellness visit to artificially inflate the medical decision-making level of your co-billed problem visit. You got to ensure medical necessity is crystal clear for both codes entirely independently. Verify your documentation proves a separate service happened, and physically ensure your HRA and cognitive assessments are living in that chart.
Because improper modifier combos are such a massive target for AI claim editing tools and those RPA bots nowadays, running regular quality assurance audits on your Modifier 25 usage is totally non-negotiable. I'm serious, these automated systems will just flag and deny your claims before a human even glances at them, if your modifier combinations are off or if your data shows you're just slapping Modifier 25 on everything across the board.
So I'm going to leave you with this absolutely crucial question to think about today. What exact steps are you going to take right now to review your wellness visit timelines, verify your mandatory deliverables like that HRA, and ensure your practice survives its next modifier audit? Please don't wait for a denial letter to realize your documentation is overlapping. Start intentionally separating your preventative coding logic from your problem-oriented logic today.
Thank you so much for joining me on this deep dive into Medicare wellness guidelines and co-billing compliance. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.